Good morning, everyone. Welcome to our webinar today. My name is Joan Batorf, and I am a professor in the School of Nursing here at the University of British Columbia's Okanagan campus and director of the Institute for Healthy Living and Chronic Disease Prevention. Before we begin today, I want to acknowledge that UBC Okanagan campus is situated on the traditional, ancestral, and unceded territory of the Okanagan Nation. I also want to acknowledge that many of you might be joining us from other regions, both near and far, and to acknowledge the traditional owners and caretakers of those lands as well. Thank you once again for joining us. We're really delighted to bring this session to you. But before we start, just a few housekeeping things. There is a closed captioning box that you'll see on your screen. And if you want to move it or turn it off, there's a live transcript button that you can use to make those changes. We invite you as well to type in your comments and questions either during the session or at the end into the chat box. So please do that. We will welcome any comments and questions after this talk. So today's event is brought to you by the Institute, and we're particularly delighted to introduce Dr. Betsy Leimbigler, who is a PhD postdoc fellow here in the Faculty of Management on our campus here at UBC Okanagan. She's been on our campus very recently, joined us in October, and came to us after completing a PhD in Berlin. The topic of the session today is the politics of health. How do political factors influence our health? And I was just saying to Betsy before we started that this is so relevant today. It seems like on the news, we're hearing about politics and health every day. So I'm really looking forward to this presentation, Betsy, and for you to help us understand how the two are connected. So I'll turn it over to you. Thank you.
Thank you so much for that kind introduction, Dr. Joan Batorf, and thank you everyone who's shown up today. I'm really excited to be delivering my presentation. So I'm just gonna go ahead and share my screen, so bear with me for 1 second as I go to full screen. And please let me know if you can see it all right. And if no one says anything, I assume you can see it on your screens. Great. So as you know, the topic of today's presentation is the politics of health. How do political factors impact our health? I wanted to start with just a very brief introduction of my research background. I am, as Dr. Joan Batorf mentioned, I'm a postdoctoral researcher here at UBCO, and my background is in political science and policy. My research interests are all kind of surrounding the concept of health equity and access to health. So my interests include health equity, health policy, social and particularly political determinants of health, as well as political communication. And I also just have a point here on the methods and methodologies that I use and that I'll talk a little bit about in my talk when I share parts of my research, because I recognize that there are a lot of people who are joining us likely from different disciplines. So whether you're from political science, policy, or perhaps nursing or social work or any other discipline, we tend to use different methods and different theories. So the methods that I use focus a lot on speech and media analysis, as well as documentary and policy analysis. So for that, I use qualitative and mixed methods using MaxQDA software. I've outlined this agenda or kind of a roadmap for the talk today with 4 distinct sections. So the first thing I wanted to do is just define key terms and share a few quotes that really introduce us to key concepts of the politics of health, just to make sure that we're all on the same page. The second part is where I'd like to share my research, and my research on health politics has focused a lot on framing and presidential power in the context of healthcare reform in the United States. The third part is where I'd like to dive a little bit more into a few theoretical concepts where I connect political factors, particularly 3 political factors: power, institutions, and policy, and connect those to current issues in healthcare. And then the last part is where I just like to have a bit of a discussion in a more broad sense to highlight the ways that political science can support health researchers and how political science and policy studies can work in an interdisciplinary way to make sense of, well, health and healthcare. So I've got a slide here. I hope it's not too small. I hope you can all read these, but I'll read all 8 concepts out as well. This is just a slide going over 8 key concepts that I pulled out. And I have time later on in the presentation to dive into a few more of these definitions. So you may have heard of some or maybe quite a few of these before, but again, just to ensure that we're all on the same page, I'll just briefly highlight, starting from the first one, social and political determinants of health. So if you've heard of the social determinants of health, these are, broadly speaking, factors that impact health, which are related to our social environment. So education, or where we're born, where we work, etc. And the political determinants of health in particular is a similar concept, but instead of our health being socially determined, it's how it's politically determined. So to dive a bit more into that, I also have this word policy. I think many of us are aware of what a policy is. It's a very broad term. One definition I like to use is policies are decisions that are either taken or not taken. I'll get into that more later. I have institutions here as well. Institutions a lot of the time are talked about as organizations or political structures. So we can look at examples, concrete examples, such as the House of Commons, or bureaucracies or bureaucratic systems as institutions. Power is a really interesting one as well. There are a lot of different interpretations of power, and a lot of different scholars look at different forms of power and problematize it as more than just weak or strong actors. So it can relate to resources, but it can also relate to different forms of power and how that power is used, which I'll get into a bit later. Partisanship, I would just refer to that in terms of adherence to political parties, and we'll see an example of that with the example of healthcare reform in the states that I'll provide shortly. Interest groups and stakeholders, this is another really core concept. These are groups that are involved in policymaking, or they may benefit or have any given interest in a policy, particularly a health policy. So an example of an interest group might be a medical association, for example. And the last 2 are quite relevant for the research that I want to share today. Frames and framing. I'm curious if anyone has heard of framing or frame theory, or just frames in general, because it's a word that we use, but there's a whole body of literature in political communication that focuses on frames. And it's a way of angling information that's specifically used by political elites, or also known as elite actors in political communication theory. So frames are more than just themes, they're more than just arguments, they are a way of angling arguments to impact the public. And then the last concept here, elite actors, I mentioned political elite actors. These are generally speaking high-profile politicians, or heads of state or powerful actors. So I just give this as an overview of some key concepts that will guide us for the presentation. I have a couple quotes here as well to zoom out of the politics of health and then get a bit more narrow. The first one is from a global health report, Global Health 50/50, and I included it because it refers to inequalities and discrimination. So the quote is, "The intersection of multiple forms of discrimination and inequalities has a devastating impact on opportunities and outcomes in global health, and things must change." This is from a report published in 2020, and I included it because without explicitly referring to politics or political science, the focus on forms of discrimination and inequalities, not just at the national level, but the global level, is really relevant. And then I have another quote here from Greer and colleagues coming from a more public health perspective. And this is from 2017. So I'll read that quote. And this quote is, it's from public health scholars who've pointed out the importance of politics. If we want to understand policies and outcomes, we need a more sophisticated understanding of political systems and institutions that shape the political processes and conditions for policy adoption. Political science should be the translational research of public health, because politics is usually what stands between our findings and effective action. To make this even more relevant, and to use a quote from Greer and colleagues from 2020, within academic circles, there's been more and more discussion about political institutions and federalism, particularly with the pandemic. So the quote is, "There will be no way to understand the different responses to COVID-19 and their effects without understanding policy and politics." And they go on to propose 4 key focuses to understand reasons for the COVID-19 responses. And I've bolded the one that is most relevant to my angle on the politics of health, which is formal political institutions, including federalism and presidentialism. So what is meant then by the politics of health? These are 2 very broad concepts, politics and health. And I can also say with conviction that in the United States, particularly an area that I did a lot of research on for the last few years, there's a really strong focus on access to health insurance, particularly in the US. Very broad discourses on who has insurance or who doesn't have insurance, which is different in the Canadian context, which is different in the German context. Some scholars look at politics of health and focus on political parties or political unions, and really focus on these institutional structures. But it can also encompass all types of funding, resources, political communication, a lot of different actors and coalitions of actors. So that includes, prime ministers or presidents or ministers or mobilized actors. I also include in here protesters, coalitions of resistance movements, and political determinants of health. So in other words, the politics of health covers a wide range of topics. And for the next section, where I'll go into my research, I want to focus on political communication and elite actors. So many of you are likely familiar with this image and might recognize this very iconic picture of former President Barack Obama signing the Affordable Care Act into law in March 2010. So this law was a really large reform, which changed a lot of things. And just to very briefly go over it, one of the things that changed was how insurance companies are able to operate. It changed how many people were able to access health insurance as well. And so one of the aims of the Affordable Care Act was to insure more people, because millions of people had no health insurance, so no coverage through an employer, or didn't qualify for a federally funded program, or were excluded because of pre-existing conditions, etc. And it's still a very hotly debated concept. Partisanship obviously plays a huge role in this. There have been a lot of attempts over the years, and very high-profile attempts from Republicans to repeal the Affordable Care Act, which many of you may have heard of as also known as Obamacare, which is a very colloquial way of referring to this policy, this act. So even the name itself has this partisan attribution to it. I'm going to show a graph here, which highlights one of the key problems that was central to the election in the United States when President Barack Obama was elected, and that's the number of uninsured Americans. So this is a graph spanning 2008 to 2017. And if you look at the circle up here, the red circle, where 2010 hits 47 million, that represents 47 million Americans who had no health insurance. And this was a growing problem, a growing cost issue, as well as an injustice issue, is how it was framed a lot of the time. And you can see how after the Affordable Care Act was signed into law in 2010, once it became implemented, the number of uninsured people began to decrease. And so this was one of the really interesting points that I wanted to look at in my research. But instead of just looking at one time frame, you know, in the previous slide, I only looked at 2008 onwards, I decided to look at a more comprehensive overview, because the more I began to do research on healthcare reform, I began to realize simply looking at one time frame doesn't give us the full picture. We do have to look historically and see how different policies that have been created at different times have impacted the systems that we see today. So the top left, we see Lyndon B. Johnson, who's signing into law Medicare and Medicaid in 1965. On the top right, this is a picture of, it's Hillary Clinton, although the time frame that I looked at was the 90s. So Bill Clinton was the president during this time. But what's really unique here is that Hillary Clinton was appointed as the head of the task force for reforming healthcare in the 1990s. And then at the bottom there, we see President Barack Obama campaigning for the Affordable Care Act. So in my PhD, I examined this long history of success and failure, because what's really interesting too is two of these images represent presidents signing into law reforms that passed, whereas in the 1990s, Bill Clinton's Health Reform Act failed. So I was interested in seeing why and digging a little bit deeper into why that is. I'm going to present here 3 quotes from 3 presidents, and they're all Democratic, so they're from the Democratic Party. And these are quotes that generally tend to sum up the concepts of each time frame. The first one is by Lyndon B. Johnson. I'll just read that out, where he says, "A great burden will be lifted from the shoulders of all Americans. Older citizens will no longer have to fear that illness will wipe out their savings, eat up their income, and destroy lifelong hope of dignity and independence." So that's a quote from 1965 during a speech. And then jumping ahead to the Clinton era, this is a quote from Bill Clinton. "There is no way that we will ever get control of the federal budget deficit unless we do something about healthcare." And then the last quote from President Obama in 2009, "Put simply, our healthcare problem is our deficit problem. Nothing else even comes close, nothing else." And what's very unique about these quotes is that the last 2 have a very strong focus on economic arguments, the economy, and budgets, even though the topic at stake is health insurance. And so that's where I began to get more interested in what is being said, how this is being communicated. This led me to research questions that I've outlined here. I had a very descriptive questions, which was, well, how do presidents and how do the media frame healthcare reform proposals and attempts? So how do they talk about these healthcare reforms? A theoretical question was, how are healthcare reform frames influenced by institutional and historical contexts? So was there a deficit at the time? What were the other historical contexts at the time? And then the observational and analytical question, where I really focus my methods, is how do frames emerge? How do they evolve and how do they interact over time, both within and throughout each of these 3 timeframes that I've selected? I conducted a literature review, and this is a non-exhaustive collection of literature on healthcare reform. So we can look at healthcare reform from many different perspectives. For example, looking at it from a global health perspective or looking at it from a political culture perspective. But the 3 ones in light blue are the 3 main theoretical frameworks I looked at, which is institutions, presidential power studies, and political communication. So why did I really focus on political communication? In political science, there is a really growing movement to use political discourse, framing, and public debate to understand these areas as integral parts of understanding government responses to health inequalities. So political scientists are really moving towards understanding how arguments come out into public debate. And there's a huge growing literature on framing literature. And this is where I did my PhD in Berlin at the John F. Kennedy Institute. There's also a very strong focus on framing and frame studies. Many empirical studies on media framing of policy issues also confirm that there are a lot of different opposing viewpoints in public discourse. So Robert Entman, Dorfman and colleagues at the Berkeley Media Center, these are just a few examples of scholars that have done large-scale analyses of media samples. Frames are used by politicians and media elites to discuss and problematize healthcare reforms. And there are some very prominent frames in the realm of healthcare reform. Two of the most prominent ones are the market and rights frames. So a market frame is essentially an argument or a frame that really focuses on economic arguments, whereas the rights frame focuses more on human rights or justice, equality. Are there other frames though? And the answer is yes, there are. In conducting my literature review, I created this sort of 6 different groupings of different discourses. So not just rights and market, but also state responsibility and federal responsibility, as well as individual responsibility and groups or collectivity. So these are some dominant discourses on healthcare reform. And what I did in my PhD research was I collected speeches, so relevant speeches on healthcare reform, and then newspaper articles surrounding those speeches. So in total, I looked at 83 speeches and 257 news media, print media articles. And through a lengthy coding process, which I'd be happy to get into if anyone has any questions about it, but I'll just go over it quite quickly here. I went from 6 to 5 different codes. So I applied all of those 6 discourses to the speeches and media samples and found, it turns out no one really talked about individualism as much as I thought they would, or as much as the literature suggested that was a frame. However, comparisons with other nations came up a lot, and democracy and concepts around democracy came up a lot. And so that's why I ended up with democracy, human rights, national or federal concern, economic or market, and comparison with other nations. In the next few slides, I'm just going to show a few visual representations of what emerged from this frame analysis. There were 3 things that stood out, and I chose these 3 because they're the most significant. The first one is the really strong emphasis on the economic frame when discussing healthcare reform. The second one, I'm just zooming into Bill Clinton as an outlier when it comes to emphasizing negative comparisons with other countries. And the third visualization I'll show is co-occurrence or mixed framing that occurred during the Obama timeframe. So I'll explain that. What we see here is frequency that I applied each code in all the documents, and it really shows this dominance of the economic or market frame. So when media or the presidents discuss healthcare reform, there's a really strong focus on economic or market arguments. The second most relevant one then being human rights or rights arguments relating to justice or equality. And then it just goes down from there: democracy, national concern, and only a very small amount on comparison with other nations. So what's really significant here is healthcare reform is discussed a lot in economic terms. But to zoom into that last one, the one that I said was rather insignificant, zooming into the Clinton time juncture, one thing that really stood out was the framing that Bill Clinton used for attempting to pass healthcare reform. In 71 media samples that were coded with the comparison with other nations, negative comparisons only occurred twice in the Johnson speeches, so in the 60s, but they occurred 34 times in the Clinton juncture. So what you see here in orange are the frequency of negative comparisons. And that's really significant. We can see by looking at this that Clinton, as as a leader or in political discourse, used a negative frame a lot more than Johnson or Obama. And this is really significant because the type of language that was used then was, Canada is doing better than us, or we are so much farther behind than Germany. So that type of language and that type of framing. And the last visual, well, the second last visual that I'll show you is focusing on the Obama juncture. As you can see, if you're just looking at this and you look at the bottom, you see the orange is media, the blue is speeches. We see a lot of focus on the economic and market codes or frames, and then less on the human rights frames. So it kind of follows the same pattern as the first example that I showed. But what's really interesting here is, first of all, the media picks up on economic arguments even more than what's shown in speeches. And it picks up less on human rights arguments than what's shown in the speeches. And the last thing is, you might think that this means President Obama or any leader is talking about healthcare reform just in economic terms. But what we can't see here is how the frames interact. So sometimes arguments are not just one frame or another, they can be combined. And that's what's called co-occurrence. So Obama's speeches on healthcare reform are unique as they have a very strong presence of mixed framing, which is a combination of two or more frames, which does not appear in the media samples. I've just shown a screenshot here from where one code that I used, which is injustice, is seen to overlap 71 times with economic arguments or the economic frame. So that's a really significant finding for the field, I guess, for political communication. And it's something that should be looked at further. So some of the findings and implications are, well, each president references the same frames, but they don't focus on them in the same way. There is a correlation between the frames on a given issue and the success or failure of a healthcare reform bill. So we can't just say that the ways in which frames are used are useless or don't matter, because there's certainly communication that's happening and then a correlation with the success or failure. Another finding is that media or the media samples don't focus on presidential frames the same ways that presidents communicate. So media does pick up on certain aspects or certain elements and then conveys that to the public. Certain frames do become more prominent, as I showed with this very strong economic frame. And then implications, one of the implications is we can create new models of analysis that focus on co-occurrence or frame interaction. And a final implication is this highlights a very fundamentally political nature of healthcare. So after doing this research, it opened the door to a lot more questions. And two of these questions were, well, how can we add in types of policy analysis and other actor groups? Because as I mentioned, I only looked here at elite actors, so presidents and media outlets, but there are a lot of other actor groups when it comes to health and healthcare reform. So what about non-elite actors, which include perhaps certain lobbying groups, health equity actors, grassroots movements, or coalitions of these actors? I've got 3 current projects that I want to briefly highlight. One of them is conducting a literature review at the moment, looking at politics of health or political determinants of health, specifically in Canada, with the goal of mapping out key actors. I've also got an exploratory project on political messaging from the Centers for Disease Control with Dr. Mike Gizzi at Illinois State University. What we're doing is highlighting key themes from press briefings and seeing how these are communicated to the public, as well as using Twitter analysis. And then I do have an ongoing project as well on task forces and federal comparisons of COVID-19 governance, and that's back at Free University Berlin. So those are the three areas that I've branched out to. So to come back to the topic, the politics of health, although the research that I showed focused on elected politicians, it's certainly not just elected politics or elected political actors. And we do need to focus more on mechanisms or processes. And those processes include understanding institutions, policy, power, and socio-political determinants of health. So I just have a few more slides to briefly go over the processes here. This slide on institutions is just to build on that definition I provided at the beginning. Institutions, they're often thought of as organizations. Hill and Verone talk about the design of political institutions, how they are unique in terms of their bureaucracies, their committees, and how institutions are political actors. And I wanted to highlight institutions because this theory, institutional theory in political science, is relied on really heavily to help us understand why systems are the way they are. So for example, if someone has this question of why are there still millions of uninsured Americans in the United States? There's no one simple answer, but looking at institutional theory can help us understand historical junctures and policy decisions that have been made over time that have led us to today. So understanding institutional context is really key. I've got also this really quick slide on policy. So just to dive a little bit more into policy, I really like these definitions. I know there's a lot of text, but I'll unpack this. So policies are created by actors or networks or coalitions of actors. And I think that is a really important point because a lot of the time, policies can be attributed to one actor or one elite actor. I give again the example of the Affordable Care Act and how it's been named Obamacare by some opponents, when in reality, you know, this policy has been created by a vast network and coalition of different actors. What's also really unique about policy is these policies are created by coalitions and actors who have biases and belief systems and who operate within institutional and power frameworks. I mentioned earlier that policy refers to decisions that are taken or not taken. And another one of my favorite, quotes to really define policy is the third one here. Health policy covers courses of action and inaction that affect institutions, organizations, funding of the healthcare system. So often we look at policy as what has passed. Sometimes we look at policies that have failed, but it's really key to also look at what is not being done and who is being excluded or the decisions that are just not being made. So policies are really essential to combating inequalities. And there's a broad area of research, particularly in the United States, focusing on structural inequalities, structural issues that can be addressed through policy, but even if a policy is created but not implemented, inequalities can still persist. And then I've got this slide on power and actor mapping. Actor mapping is a tool that I use, that some people use to visualize the constellations of actors. Suri Moon is a global health scholar who's got a great quote on how actors, often perceived as weak or powerless, might actually be able to wield influence in ways that are not widely recognized. So she takes this idea of power, which sometimes is viewed simplistically as sometimes we have politically strong or politically weak actors, and says this is not thorough enough. Sometimes if we say an actor is weak, they might not be weak. They have a different form of power. And this is really relevant for understanding the politics of health. And I'm using an example here. It's just a quick visual, and I know it's probably too small for most of you to see, but this is just a quick example of actor mapping, And I've done this with a few different policy issues where I've done an overview essentially of media samples to skim and search for main actors involved in any policy issue. And what you see here is mapping different forms of power, in this case, institutional, discursive, political, and economic power, and mapping actors around those forms of power, just to give us a more nuanced view of the types of power that different political actors have. So the last section of my presentation is going to go over social and political determinants of health very quickly. I've got here an image, which is from the Kaiser Family Foundation, on social and economic factors that drive health outcomes. So I've included it because it's a good visual of what we mean when we say social determinants of health. What's interesting is they've also added in economic factors. So economic stability obviously impacts health outcomes, neighborhood and physical environment, education, food, community and social context, as well as the healthcare system. These are the areas that they've outlined driving health outcomes. What's missing from here is the explicit mention of political determinants of health, or political factors that drive health outcomes. So political determinants of health involve the systematic process of structuring relationships, distributing resources, and administering power, operating in ways that reinforce or influence one another to shape opportunities that either advance health equity or exacerbate health inequities. And this is a quote from Daniel Dawes, who's written on the political determinants of health from a US perspective. And what's really key about this is that focus on political determinants with their ability to either advance health equity or exacerbate health inequities. He particularly looks at three different areas: voting, government, and policy when it comes to key political determinants of health. And I also have a quote here from Ilona Kickbush, who's written on political determinants of health at the global level. It says here, health is a political choice, and politics is a continuous struggle for power among competing interests. And so what I'm working on at the moment, the main thing that I'll be working on as well moving forward is a determinants of health model that can incorporate political as well as commercial and corporate determinants of health. So this is something I've been working on with Dr. Eric Lee, as well as Dr. Sri Seaton, Dr. Kathy Rush, because we're trying to really integrate this also into the Canadian context. Given how central, what I showed in my previous research, market framing and references to the economy and markets are, and given how central politics are, we argue that we need a more updated model to integrate politics as well as commercial and corporate determinants of health. So the next steps are to focus on political determinants of health in the context of Canada, and what I would then roadmap would be to start doing actor mapping and mapping out key actors as a first step. Just to briefly recap, and then I have a few discussion questions as well. Healthcare and healthcare reform is strongly connected to power, institutions, and policy. So if we're trying to make sense of the politics of health, really focusing on these definitions of power, institutions, and policy give us really important tools. Framing and political communication are also really key. And I wanted to illustrate how there's a growing literature and growing methods and research on understanding political communication and framing, which I would argue is even more key, of course, during the pandemic, and seeing how political messages are communicated during emergencies. We can systematically analyze speeches and media samples to show this. And just as a final recap, I think one of the key takeaways is also that we can understand inequalities and disparities as political choices or policy choices. So using it from that angle, understanding inequities as a political choice or a lack of choice is one of the ways that political determinants of health can help us move forward in understanding how to combat health inequity. So I want to leave with a few discussion questions here. I'd be very keen to hear from any audience members, whether you've used similar methods before or similar approaches. The first question that I would have for the audience or for a discussion is, what do you think are the most crucial political aspects of COVID-19 governance, and at what level? So when you are trying to make sense of COVID-19 arguments or decisions that are being made, are we looking at this from the global, at the federal, provincial, or more local level? A broader question about interdisciplinarity. I'm really interested in how does your discipline approach politics and health research? And then the last question, how do certain political factors such as resources or political parties, power, how do they impact Canadians in different parts of the country who have very different experiences? So that includes, Canadians in different regions, Canadians who have different levels of access. So these are just some discussion questions to kick off the Q&A. And I really thank you for bearing with me and letting me share my research with you. I'm really looking forward to the discussion. So thank you very much.
Thank you so much, Dr. Leimbigler. That was really interesting and such a refreshing perspective, moving away from sort of blaming individuals for their poor health and health behavior choices to looking beyond that to other factors in the environment that are actually creating these inequities. And so thank you for that. It was really interesting. I'd invite people to add their questions and comments and any discussion that you want to add to our presentation today as a result of the questions that have been posed as well. I invite you to join in on the chat and add any comments or questions. I see that we have one from Sanjoy here already, so let's begin with that. And it's a question for you. Can you please provide an idea of how social media is changing the role of traditional institution in terms of policies? And I'm assuming that that means policies affecting health in some way. But yeah, you didn't mention social media, but we seem to be hearing a lot about how social media is changing the way people think about things these days.
Mm-hmm. Yeah, thank you, Sanjoy, for that. That's a really, really great question. It's something that I did not mention that because, I do have some colleagues who are doing more social media analysis, and with Mike Gizzi, we are trying to do more of a Twitter analysis. And one of the challenges is just the volume of tweets to analyze. And so I can see how political communication scholars are trying to catch up really quickly to find ways to analyze social media. But your question, the first thing that I think of when I hear of how social media is changing the role of traditional institutions, I do think of some of the dangers of it in terms of misinformation and how we do need to have a better understanding of algorithms and how what we see in social media is presented to us based on different algorithms or based on things that we don't see in traditional media, because you're right, I looked at print media for my dissertation, for example, and the reason for that was simply because of consistency. So to look at 3 different time periods, to look at social media on top of print media would have, then maybe I should have just looked at one case study. I think that that's a direction that is urgently needed. And like I said, there's a lot of different forms of research going on with Twitter analysis, as well as Facebook comment analyses. So looking at news articles that are posted on news channels, Facebook pages, and then scraping those and analyzing those. But yeah, social media it's definitely changing the role of traditional institutions. And researchers, I think, need to really focus on how we can analyze that, first of all, but also the wider questions that has for democracy in general, because it is so new.
Great, thank you. We've got a couple of other questions here. So Dr. Lee, Eric Lee is asking, I wonder whether you're planning to compare the Republican presidents, i.e. Trump, with the Democratic presidents.
Yeah, thank you, Dr. Eric Lee. It's a great question too, you know, comparing Republican presidents to Democratic presidents. And that would be another angle to take, because for the research project that I presented, I looked at the puzzle, which was we have Democratic presidents and then we have one outlier where a reform didn't pass. And another reason that I selected it that way is because the most major healthcare reform bills have been passed under Democratic presidents. So I think you absolutely could do an analysis where you compare Republican presidents with Democrat presidents. The design would look a bit different, but you would see really interesting things. I would personally be really interested in seeing someone continue to do that work, and maybe, if anyone is interested in doing an analysis of contrasting partisan approaches like that. So I think that's something that people are starting to do. I know a few students who have started doing analyses of Republican presidents as well. So I haven't really begun to compare those presidents, Republican versus Democrat, but it has come up in Mike Gizzi and I's analysis of CDC statements. And the Center for Disease Control is not partisan, and yet during the press briefings and particularly when reporters are phoning in, there are partisan elements to that. So even though I wasn't planning to look at that, it just still comes up. So thank you for that question.
Yes, it actually reminds me that there's so much data there that is so interesting to analyze if we had the time to really look at it. Dr. Minton also asked a question. We've seen widely different interactions in BC versus Alberta with respect to the interactions between politicians and public health officers during COVID. From your perspective, how would one approach to analysis could be used to understand these different interactions and their impacts on health outcomes?
Yeah, thank you so much, Craig. I really like that question, because we've got this example right here, right, between these two provinces with very different perspectives. And I like that you asked that, because my mind immediately goes to the different forms of analysis, or the different research questions we would have, and then how we would analyze it. And I could see both a policy and a frame analysis as research designs to analyze, the differences between BC and Alberta from the beginning of the pandemic. So in doing a policy analysis, I'd be really interested in reconstructing timelines of measures that are implemented and then taken away. And so looking at timelines as well as task forces. So not just what the premier says, but also, are there any task forces? Are there any experts that are being consulted? And kind of overlaying that in the timeline. And I say that because that's what I've been doing at Free University, but not at the provincial scale, at the comparative scale between different countries. Because we can look at how federal governments are implementing restrictions through a timeline sequencing. But with respect to BC versus Alberta, I think that would be a really, really interesting comparison, to look at the timelines there, and then to see if task forces have been assembled and what the advice has been. And then I think you could also do this frame analysis as well, where doing a sort of speech analysis or a public messaging analysis of the premiers can be overlaid on top of that. So that's what I see. And I would be curious if you're interested in doing that. I would love to know what you find, but that's how I would approach that. That's the analysis that I would approach that with.
Yeah, that's interesting, especially the frame analysis. And maybe a follow-up question to that is, when I think back to some of the speeches by our premiers across Canada at various points in time, sometimes there was a very emotional frame. And I didn't see that in your category of frames. And so I'm wondering if that is a frame that's worth considering or not. But there was often a very emotional tone to the speech, or to at least part of the speech.
Yeah, that's a really great point. I'm really glad you brought that up, actually, because you're absolutely right. When I was doing this speech analysis, the closest thing that I ever came across in the speeches I analyzed on healthcare reform were anecdotes. That was probably the closest thing I could find, where this came up only with the Obama speeches, for example, where anecdotes such as, I spoke to a mother in Wisconsin, or I spoke to a dad who was struggling. And so there's bits of emotional response there, but it was really different. Like, it is quite different from, I would say, what we've seen with the COVID-19 messaging, where there's been so much more or such different emotion because of the unknowns there. And I know that Weibel and colleagues who are in policy sciences, they recently published in 2020, so right at the outset of the pandemic, guidelines for policy researchers saying we should have more analysis of emotions. So you're absolutely right in highlighting that this is something that should be done, and that policy researchers are saying it's actually quite valuable to look at the types of emotions that have come out, and is there fear, is there, what types of emotions are there?
Mm-hmm. Yeah, and I guess I would be interested in knowing what difference that makes to either changing public views or to support for various policies. And I guess that relates to all of those frames, is that, are politicians following this kind of research to figure out how to frame their speeches?
Yeah, well, I think when it comes to the pandemic, the most important part would be consistency of messaging. So I think it's interesting to look at the emotions that come out. I think that if someone's doing an analysis on consistency of messaging, you might as well also code for the emotions, just to see what does come out. But I would say, yeah, that's a great point that you've brought up. One of the key things would be maybe not why the emotions matter, but is there a consistency? And that's where it becomes really interesting, looking at different levels. That's something that's been seen as well. If one locality has politicians or elite actors or public messaging, which is contradictory to, say, the provincial messaging, then that's where those interactions just, they're inconsistent. So I think an emotional analysis there, that would be really interesting, but I also would probably focus more on the consistency. But I guess it is still important to look at emotions, because it is, still, it's an emotional concept, it's an emotional time, and we can't just assume that we're completely objective about it.
Yeah, exactly. Yeah, interesting topic. I see there's another question from Sanjoy here. Any idea on the role of the educational level of the policymakers that play a role in policy determination?
Interesting. Yeah, thanks, Sanjoy. An idea on the role of education level of policymakers. I haven't really looked into that, I have to say. And one of the reasons is because I think of education level, and I know there are ways of measuring education level, but then it sometimes won't take into account formal versus informal or non-formal education. So that's one thing I would look at, and be a bit, want to dig a little bit deeper into what we mean by education level. But one thing that your question does hint at, when it comes to policy determination, I wanted to bring this up. There wasn't time, but evidence-based policy is a really interesting point that kind of relates to your question. And essentially, we can have evidence that certain policies will result in a beneficial outcome. That doesn't really matter what the education level of the policymaker is. I would attribute that more to belief systems or values. So what I had mentioned briefly in the policy slide, and a lot of policy studies now understand that individuals, which includes politicians and policymakers, have sets of values and belief systems. And it's not just individuals, it's the institutions and the coalitions have this too. So maybe I would add to your question that perhaps it's maybe not the education level, but values and sets of beliefs within policymakers that play a role in policy determination. Because sometimes policymakers can have sets of beliefs that may be opposed to evidence on a given policy issue. So if we know that passing this policy will result in, an increase in health or a decrease in issues, but it's not taken up, it's because of, well, it's basically, we have the facts, but facts don't always, get the message across. And I think that's something that people are really frustrated with. And that's probably why there's been such a growth in framing research. It goes back to Joan's question of what about emotions here? So it's a very roundabout way of saying, no, I haven't really looked at education level of policymakers, but I would focus on values and belief systems of policymakers, how that determines policies.
Great, thank you. I guess the other thing that comes to my mind related to policy determination, especially when I think about our past year and the differences across the province, it does seem like the provinces have done that in very different ways. And I mean, what I see is what I see on the news, like everybody else. I'm not behind the scenes, but even by the fact of who speaks to the public, I think is a huge reflection on who's making the decisions and who's determining the policy. And it's been quite different. Even the way that people are projected on the TV screen, and I'm sure it's all orchestrated. And it's just so different. I mean, just even thinking about Ontario and BC and perhaps even Alberta, they're just so different. And they've changed over time. Ontario has changed over time a bit in terms of who communicates and how they communicate and who's presented and even how they stand around the premier. I mean, it's been fascinating to kind of watch.
Yeah, and it's all part of political communication in that way. And that's interesting also, again, to observe how it changes over time. And I think that's where, systematically looking at timelines and putting in these different analyses can really help us make sense of the last couple of years. Yeah, thank you.
So would you analyze not only the speeches, but also the context in which they're given? And, are they given from the Oval Office, or are they given on, in a town hall, or, with other actors around them? And, I mean, there's lots of contextual factors that are also communicating the messages here.
Yeah, 100%. And one thing that really is, you can expect it, but I did the analysis and found that there are a lot of these high-level speeches that just have nothing to do with any frames that you'd think they would have to do with. So State of the Union speeches that don't really mention health, even though it's such a key issue. But then when you look at a speech that is, like you said, geared towards a more local audience or geared towards certain stakeholders, then the language changes drastically. So it's definitely something to be aware of as researchers when we look at speeches, or the contexts make all the difference, and the audience makes a huge difference. Yeah.
Well, this has been really fascinating and leaves us, I think, all wanting a little bit more. So I think you'll have to come back and tell us about your research in the Canadian political and health context when that's finished. So I see we're out of time. So I do want to take this opportunity to thank you once again for joining us today and sharing this research and getting us all thinking about politics and health in perhaps a new way. So, and I do want to thank everyone who joined us today as well, and for your questions and participation. And so with that, I'll say goodbye. And once again, thank you. Bye for now.
Thank you.